It's my pleasure now to introduce Professor Gamal Al Saady. He will give us a talk about hypertension post-renal transplantation. Professor.
Bismillah ar-Rahman ar-Rahim. It's a real great honor to me to be sharing with you this very simple topic to the Egyptian Society of Hypertension. وأستاذنا وأستاذي الأستاذ الدكتور محسن إبراهيم هو اللي معلمنا الكارديولوجي والهايبرتنشن والميديسن كله. And I thank the organizing committee كل الأساتذة الأفاضل for this very kind invitation. Actually, I am going to cover the probable relevant risk factors and targets, how to assess the hypertension after transplantation, the different etiologies. We will go through the management, and we should not forget the donors and if they have any risk of hypertension among the general population. Many of the patients who are going to be transplanted, 80% of them have already hypertension. And after transplantation, they might probably recover from this hypertension, but in a certain percentage of patients, they may persist having this hypertension. And in the 20% who are not hypertensive, they might still continue to be normotensive, or occasionally they might develop hypertension. Kidney transplantation by itself is a management of the hypertension, and there is a significant reduction of the blood pressure after transplantation. And it's reported to have hypertension in 70 to up to 90% of the cases, and the consideration of the ambulatory blood pressure monitoring would discover much more cases, particularly the abnormal diurnal blood pressure patterns, and we might encounter hypertension according to the baseline of 120/70 in more than 95% of the cases. And actually the non-dippers and the ambulatory measurement direction of detection of hypertension has an important relevance to the occurrence of deterioration of the kidney function. The ambulatory blood pressure would detect hypertension in more than 95% of the cases, and it is very crucial because it is still the most important risk factor for mortality in CKD and transplanted patients, having the cardiovascular risk as the most important leading cause of death. And as well, it is an indication of deterioration of the graft function. So it's important to detect any rise of the blood pressure as well as proper management. And the relevance to the death-censored graft failure, it is very clear that it is related to the occurrence of hypertension, resistant hypertension, or uncontrolled blood pressure, with the uncontrolled hypertension bearing a great important relevance to the death-censored graft failure. And to consider the targets of the blood pressure, it's still debatable, the target blood pressure among the general population, but the cardiovascular mortality and all-cause mortality might be related to 130 or below 140 to be a better hazard ratio for the occurrence of cardiovascular or all-cause mortality, better than those who are below 130 millimeter mercury. And this is mentioned in the guidelines, in the KDIGO guidelines, where blood pressures below 140 and above 130 might be considerable if we have no other risk factors. But with the occurrence of organ damage or related to the hypertension or occurrence of CKD, whether stage 3 or greater, this might be not relevant, and we might have a risk for considering this as a normal blood pressure. And we need to go a bit lower than the 130 to 140 systolic blood pressure. The European Society of Hypertension guidelines consider in transplant patients that the target blood pressure should be below 130 and below 80 millimeter diastolic. And it should not go lower than 120/70. We should not be extremely controlling the blood pressure below this level. Because below this, we can get excess deterioration of the cardiovascular mortality, all-cause mortality, and kidney function in such patients. And the diastolic blood pressure as well, we should not go below the 70, because below the 70, we get deterioration of the graft perfusion. The current guideline of the KDIGO occasionally mentioned that we should consider a target below 120 millimeter mercury, and Professor May will extrapolate on this. But this might be deleterious, particularly in patients with CKD stages 4, 5, glomerulonephritis, polycystic kidney, and proteinuria, because they consider having proteinuria is a target to lower the blood pressure even lower than this. But it seems, and this is a very recent publication and study by the USA in 2024, we can target only higher blood pressures in older patients, and we can consider 140/80 as a better target for such patients. About the assessment, we can have the standardized office blood pressure, and we can augment this by home measurement. It's very crucial to consider ambulatory blood pressure measurement and assessment in such patients to detect any rise of the blood pressure, as it might influence the mortality and the graft functions. Yet the UK guidelines consider that the office blood pressure is the base for treatment decisions and could be assessed by the home assessment as well. They highlighted the different methods for standardization, but they consider that the manual or the oscillometric measurement is a better way of measurement of the blood pressure. The KDIGO considered that the automated office blood pressure, whether attended or unattended, may be the preferred method of standardization of the office blood pressure, and this should be augmented by the home or the ambulatory measurement. It's important to consider the ambulatory measurement because it will detect any masked hypertension or white coat hypertension. And it was found to be an important predictor of renal function decline. And it is now considered a priority to consider the ambulatory measurement or assessment in one phase, particularly in the early post-transplant period. About the etiologies, they might be related to non-immunological factors, whether donor or recipient, as well as occasional surgical factors, renal artery stenosis or polycystic kidneys. Also, it might be related to immunological factors related to the graft function or to the use of the immunosuppressive agents, which are related to introducing hypertension by themselves. The factors in the recipient might be related to genetic factors, particularly APOL1 genes and other genes, presence of comorbidities, particularly diabetes and obesity, and the use of calcineurin inhibitors as well as steroids. Also, the same factors in the donors, whether we have genetic factors or they are marginal or extended criteria donors, older donors and female donors because of the size of the kidneys. Also, the long-term function of the graft might be related to the hypertensive process, and the delay in the detection of the hypertension by the physicians might be another factors. This highlights the importance of the somatometric characteristics, female to male, or young donor to a bigger donor, female to male, pediatric, this is in cadaveric, pediatric to adult. And we can have immediate post-transplantation hypertension in the very early post-operative period, or early post-transplant hypertension in the first 3 months, or we can have late post-transplant hypertension after 6 months. Considering the assessment, the management in the KDIGO, they mentioned that dipyridamole, calcium channel blockers, or angiotensin receptor blockers can be used as an initial line of treatment, and this is grade 1C. And I don't feel that this is very appropriate, because it is preferred, particularly here by the UK guidelines, that we should try to avoid the ACEs or ARBs in the first post-operative period, particularly in the first 3 months, and more important in the first month. Try to avoid them as much as possible. And they should be only kept for patients who have proteinuria or heart failure. And the European guidelines mention that the calcium channel blockers are more important to be used as the first line of treatment, and particularly that they antagonize the effect of the CNIs. But when we are obliged to use the ACEs or ARBs, they are of great importance, and they reduce the risk of graft loss by 38%. And in head-to-head comparison between the calcium channel blockers and the ARBs in such patients, they found that the calcium channel blockers might be more beneficial, and they increase the GFR on the long term. And this is one of the important slides here, considering individualization of the treatment. And we should consider lifestyle changes, correction of obesity, moderation of life and exercise, as well as considering calcium channel blocker as the first line of treatment. With what? This column coming is important. If we have proteinuria, they consider RAS inhibitors, spironolactone. SGLT2 is considered here as a antihypertensive measurement, as well as the selective mineralocorticoid receptor antagonist. They are considering now SGLT2 inhibitors as a management of the hypertension of the proteinuria, even if we don't have any stage of CKD, but usually they are in stage 2, and regardless of the having pre-diabetes or diabetes. If they are edematous or hypertensive, we can include the diuretics. And if we have heart failure, we can add, in addition to all these measurements, the beta blockers if we are in need of more control of the blood pressure. This algorithm highlights the interventions after kidney transplantation, whether we can use exercise or diet in different types of patients, particularly in the very early phase, is not very feasible. We can use the diuretics accordingly if they are retaining fluids. But what is important here is to consider calcium channel blockers as the first line of treatment, to be augmented by beta blockers. We can utilize alpha blockers. Then we should include the RAS blockers and the MRAs, particularly after bypassing the first months of treatment. We can later on add alpha-2 agonists, alpha-methyl dope, and so on, if we have more need of control of the blood pressure. Further procedures, particularly the surgical procedure, might be considered if we have renal artery stenosis. The percutaneous transluminal angioplasty might be considered, and it is very successful. Native renal denervation is not that successful. Occasionally, in very resistant cases, we might consider bilateral native nephrectomy. The European Society guidelines mention that if we have renal artery stenosis, the percutaneous balloon angioplasty might be very successful. And they studied occasional cases who might require native, post-transplantation, native bilateral nephrectomies. And they found that post-transplant bilateral nephrectomy might be very successful in controlling the hypertension. But what is more important in their findings is that they had lesser one-year acute rejection. My last a couple of slides about the hypertension in the donors. The all-cause mortality in this category is better than the general population, but this is a bias because they are very selected population, and we are comparing them with the general population having a lot of comorbidities. But it is encountered that they don't have any significant hypertension. Probably they might have diastolic hypertension which is very minimal, and we should consider this in the context of having generally a lower estimated GFR, probably in the stage 2 on the long term. Finally, Mr. Chairman, the post-transplant hypertension is prevalent in more than 80% by the office blood pressure and more than 95% by the ambulatory, considering 120/70. The cardiovascular disease and mortality is still the highest risk factor in kidney transplant patients, with impact of hypertension on the graft survival itself. We might encounter de novo hypertension, not only residual or resistant hypertension. We can encounter the hypertension in the very early phase, and we still can have late occurrence of hypertension. Calcium channel blockers should be the first line of treatment and preferred line of treatment. We should consider individualized comorbidity-directed therapeutic modalities and selective on-demand surgical interventions on demand. And thank you very much for your attention.
Thank you very much, Professor Gamal. May I ask you, maybe it's to me, it's a little bit simple question, but what about after renal transplantation, you transplant a new kidney and you spare the others, or they will keep? Is there any mechanisms for hypertension for the non-functioning kidneys?
They might be still functioning as a cause of hypertension, particularly if we have vesicular reflux. We occasionally require nephrectomies. If we have residual massive proteinuria, particularly in the children, they might require native nephrectomies pre and post transplantation. Occasionally, polycystic kidneys might be a cause of hypertension. Occasionally, as well, small kidneys might be producing a loss of catecholamines and renin-dependent hypertension. And in cases which are very resistant and you prove the occurrence of excess renin production by the native kidneys, we might proceed to the bilateral native nephrectomies.
Thank you very much.